Thank you, everybody, for the opportunity to present our work. Specifically, we are interested in characterizing lower extremity burns in persons with diabetes and evaluating the likelihood of amputation, which is the worst case scenario. I'll cut to the chase and say that we found that the presence of diabetes in persons with foot burns significantly increased the likelihood of an amputation. Here we'll present a little bit of the background on foot burns, a few other interesting secondary outcomes that we found from this analysis of a large database. And also, we think that foot burns in and of themselves are a completely different clinical entity and so should be treated as such. Therefore, in combination with collaborators at University of Washington, we developed a protocol for systematically treating these patients. And you can see that on the graphic in the top or the bottom right on this poster here. Okay, so just as some background, any foot wound in a diabetic person obviously is a huge problem. And foot burns are even more so. Those with diabetes have thinner skin, less vascularity, often peripheral neuropathy, and in effect, this translates to worse outcomes overall, such as increased length of hospital stay, greater need for hospitalization in the burn literature, greater need for skin grafting, risk of infection, and then worse scarring. Here, we assayed the National Trauma Data Bank and looked at the incidence of amputation in hospitalized patients. We also looked secondarily at foot burns over time, length of stay, and discharge disposition. Overall, we found that there were a little over 100,000 adult burn encounters. Almost 8,000 of those were foot burns, and of the foot burns, 1,300 had diabetes, roughly. I'll take you to this first table. First, we found that those with diabetes and foot burns tended to be older, male, African-American, or Black race, have more comorbidities, smaller burns, so total body surface area less than 10%, and more likely from scald injury. And figure 1 shows the increase in incidence, both incidence and occurrence of amputations in diabetic foot burns over time, which was quite surprising. Finally, in table 3, we looked at the independent predictors of amputation in those with foot burns, and we found those to be age, male sex, diabetes, alcohol use, renal disease, burn size, and surprisingly African-American or Black race. So in summary, those with diabetes are 3.7 times more likely to undergo amputation than those without after a foot burn. Given this and increasing incidence of diabetes, there's clearly a need to prevent foot burns altogether, and this can likely be done with amputation. In the event of a foot burn, we have proposed an algorithm to treating foot burns, which you can see below. And then also, as another point, it's really surprising and saddening that African-American race is an independent predictor of foot burns. So clearly this is an area of study that needs a lot or needs further investigation. Going through the algorithm here, we start with a patient that has a lower extremity burn. They present. We, of course, treat the diabetes and assess how severe the diabetes is, and then get x-rays to look for evidence of bony infection, because often these patients present in a delayed fashion. If they have bony infection, we consult ID. If they have evidence of longstanding diabetes and peripheral neuropathy in the form of Charcot foot, we get podiatry on board very early on. This is an often overlooked and a very important step, since offloading is an incredibly efficacious modality for treating any diabetic wound or diabetic foot wound. If the wound is infected, we take them to the OR for excisional debridement. If the wound is not infected, we do a very good vascular workup and consult the appropriate services. Post-operatively, glycemic control is a big issue. Offloading, very strict, and we work in concert with podiatry. In very select cases, hyperbaric oxygen therapy has been shown to be effective, specifically in cases of chronic underlying osteomyelitis. Thank you, everybody, for listening to this talk. If anybody has any questions, please feel free to reach out. My email is in the form of a QR code at the bottom right of the poster here. Thank you.